Hi, today we'll talk about identifying a mismatch between the amount of support delivered by the ventilator and patient's demand. This mismatch can be noted in any mode, although modes where work shifting occurs are more prone to it. As you may remember from Module 2, work shifting refers to an expected decrease in the work performed by the ventilator in response to an increase in inspiratory work exerted by the patient. This relationship is seen in volume control. Since flow is the limit variable, the stronger the inspiratory effort exerted by the patient, the less pressure the ventilator will have to apply to achieve preset inspiratory flows. Work shifting will also occur in pressure-limited modes where the ventilator will titrate the applied inspiratory pressure to achieve a target tidal volume. The more inspiratory effort the patient exerts, the higher tidal volumes will be. If tidal volumes are higher than the set target, the ventilator will apply lower inspiratory pressures. Hence, work shifting is inherent to these modes. The more work the patient exerts, the less work the ventilator does. Does that mean that these modes are inherently bad? Certainly not. It means that in the subset of patients with increased work of breathing, these modes may make it easier for a mismatch to occur between the amount of support we deliver and the amount of support that our patients demand. Regardless of the mode we use, our waveforms can give us an idea of how much effort the patient is exerting. In pressure-limited modes, we will see a decrease in area pressures and an increase in inspiratory flows in response to patient inspiratory effort. In flow-limited modes, we will only see a decrease in area pressures. Although the magnitude of these changes will point towards how much effort the patient is generating, looking for signs of respiratory distress, such as tachypnea and the use of accessory respiratory muscles, is generally needed to say that we are observing a clinically significant mismatch between the amount of support we're delivering and what the patient demands. Let's look at a case and discuss how we can troubleshoot insufficient inspiratory support. Here we have a patient on volume control with a constant flow pattern. Compare the pressure waveforms from our patient with how they would look like in a passive one, shown in the red rectangle and drawn with the blue dashed line. Note large negative deflections in the pressure time graph painted in white. See how area pressures go consistently lower than PEEP, shown here with an orange dashed line. In fact, there are moments where area pressures drop even below zero. The patient was exerting vigorous inspiratory effort in an attempt to receive higher flows. Since the ventilator controls inspiratory flows, flow will not rise in response to inspiratory effort, leading to this remarkable drop in area pressures. This mismatch between demand and supplied flows is often called flow dyssynchrony. Increasing tidal volumes is probably the most effective way to match the patient's demand, although this is often not clinically appropriate. Just increasing inspiratory flows without increasing tidal volumes may also help with this abnormal patient-ventilator interaction. Depending on the ventilator, this can be accomplished by increasing the flow rate directly, or if this option is not available, you have the option to decrease the I time. For the same tidal volume, a shorter I time will require higher inspiratory flows to be generated by the ventilator. This is what we did here. Note how inspiratory area pressures don't go as low as before. The patient, however, still had signs of increased work of breathing, and increasing tidal volumes was felt to be clinically inappropriate. So the best next step in this case was to sedate the patient to suppress their elevated respiratory drive. This is it for today. Next week, we'll discuss a couple more cases of inappropriately low support. I'll see you then.